Odontogenic keratocyst. Earlier, it was known as keratocystic odontogenic tumor in the year 2005. But later in the year 2017, this was discarded to be called as keratocystic odontogenic tumor. However, earlier it was called as keratocystic odontogenic tumor because of its higher rate of recurrence. It was considered to be malignant and discarded in the year 2017. So, what are the types of odontogenic keratocyst? There are four types of odontogenic keratocyst. First is the primordial or the replacement type, that is, it occurs in a previously extracted or missing tooth and it often mimics as a residual cyst. Next is the envelopmental type, that is, it develops or surrounds an unerupted tooth, and so it can be confused as dentigerous cyst, and it is often said it mimics the dentigerous cyst in the X-ray. The key feature is how we will differentiate it. This histologically we differentiate, as dentigerous cyst will have keratocyst. Now the third type is the collateral type, that is, this cyst develops adjacent or between the roots of the teeth. It is often confused with the lateral primordial cyst. And the last is the extraneous type, that is, it develops away from the tooth, that is in the ramus. So first one you can see here, this is the my replacement type, which is often occurs in the area of a missing or extracted tooth. Next is my this is my collateral type, it occurs between the roots. Then the this envelope type, it occurs or surrounds an unerupted tooth. And the last is the extraneous type, it develops in the ramus, that is away from the tooth. Now coming to the histopathologically, what is OKC? OKC is a developmental odontogenic cyst which develops from the dental lamina, that is the cell rest of caries. It is known for its aggressive behavior and higher rate of recurrence. Now this question mostly they'll ask you that why it has got a higher rate of recurrence. So the answer is, it has got a thin fragile lining, and this is very important, that it has got the residual daughter cyst or the satellite cyst, and incomplete removal makes the OKC to have a higher rate of recurrence, but mostly it is because of the daughter cyst or the satellite cyst. Histopathologically, if we see, it has got a thin lining, the lumen is filled with keratinous debris. This epithelium here, it is only 6 to 10 layers thick, and the basal cell has got this pricket fence appearance. This is pricket fence appearance, and the nucleus is at the same level, which we call as pricket fence, and this has got a palisaded appearance. Okay, you call it as a palisaded basal cell appearance, basal layer. And the above topmost layer is it is parakeratinized with a corrugated and wavy appearance. Now mostly OKCs are asymptomatic, but often it can cause swelling, pain, displacement of the teeth, and cortical expansion or perforation. And this expansion is in the anterior posterior direction, that is in the direction of follows the path of the jaw. This bone expansion is in anterior posterior direction. Now gender prediction, if we say, that is, it has got more slightly male predominance. Higher rate of recurrence, I have already told you. Now what is the treatment? Enucleation and curettage. Mostly if we'll call it as enucleation and peripheral osteotomy. So most accepted treatment to reduce recurrence, it involves removing the cyst and scraping the adjacent bone to remove daughter cyst or the satellite cyst. It may be combined with carnoid solution to chemically cauterize the residual cells. Now what are the syndromes which is associated with OKC? It is the nevoid basal cell carcinoma, also called as Gorlin-Gott syndrome. Here you can see multiple OKCs, basal cell carcinomas, bifid ribs, calcification of Fox cerebri, and frontal bossing and hypertelorism. Okay, you can see this frontal this calcified cerebri, increased ocular telorism, odontogenic cysts, multiple basal cell carcinomas, epidermal cysts are present, bifid rib is present. I'll show you better. Bifid rib is present, then palmar frontal plates are present. Okay. Now, if the question comes whether OKC is benign or malignant, so it is benign, but it is aggressive, very aggressive, can rarely transform into squamous cell carcinoma, malignant transformation, especially in long-standing untreated cases. Differential diagnosis: dentigerous cyst, ameloblastoma, and radicular cyst. Okay. So yeah, one more thing, the gene involved in OKC is the patch 1 gene, and the chromosome is the 9q chromosome. Okay, I hope this is clear. If you have any doubt, you can ask in the comment section. Thank you.